Hello, everyone. Thank you very much for tuning in. My name is Steve Nuri, and we're going to have a very interesting panel discussion today. So, first of all, I would like to start by sending our prayers to all the people in India who are being facing this devastating new wave of COVID. All of our thoughts are with you, and hopefully, you will get through this surge as soon as possible. Um, we will wait a little bit for everyone to join because it will usually take a bit of time for the audience to sign up to the links. But hopefully within a couple of seconds, we will start our conversation. This is going to be a very interesting panel discussions, and I'm joined by great panelists, professors from universities and academics, researchers. They are going to share some interesting insights. I am not a healthcare professional, but I will try my best to share my experience and expertise in AI and data science and I guess, the use cases and maybe some newest projects that we have seen in terms of the latest technology that has been leveraged to tackle the challenges that we are facing. We're getting a lot of comments. That's awesome. That's great to have you guys here. Yeah, let me know if you have any questions from our panels. Our discussion topic is going to be about the mental health, and especially mental health during the COVID and the crises. We all have been impacted by these problems around the world, more and less, maybe directly or indirectly. But anyway, this is something that is still going on in many different countries. And this is still a hot topic. In crises are something that usually would impact the smaller regions like bushfires and floods in Australia, in regional Australia. But the pandemic just showed that there can be some problems that we will face as a human, and we need to stand up and help each other to go through this. So let me know if you have any questions from our panelists, if there is any specific things you would like to know about it, if you're facing any challenges. And also, we would like to know that where are you tuning in and where are you from? It's going to be a global issue, and we would like to see people tuning in from different part of the world and hear from them, and if they're going through any particular challenges in their own regions. So without further ado, I will start the discussions. So we are going to talk about this important topic today. We have an amazing panelist going to help us move our conversations. That we're going to talk about healthcare in crisis, as I just said, and the impact of COVID in the communities. Also, maybe we dive into some solutions, especially leveraging the latest technologies and AI, and the ways that in which our panelists have been leading the way in terms of dealing with this particular crisis. I'm going to co-host this with Professor de Souza, and as I mentioned, that this is going to be around the context of crises like COVID-19, and the mental health is going to be probably a secondary problem in these crises. We all have been impacted in terms of the health, but also there are other impacts like economic challenges that cause many of us to experience depression, anxiety, and other mental health consequences that in a smaller scales, like disasters, other disasters, we also have seen the similar problems. So I'm going to announce the panelists. We're going to hear from Professor Wendy Chapman, who is the director of the Center for Digital Transformation of Health at University of Melbourne. Please introduce and you can talk a little bit about the work that you've been doing in this particular area.
Yes, thanks for this opportunity. So our center is housed at the University of Melbourne, and our goal is to really better leverage data to drive healthcare improvement, and also figure out better ways to implement and translate research into practice. I come from the United States, where I was chair of the Department of Biomedical Informatics at the University of Utah, and my personal research area is natural language processing, which is using computer algorithms to process and understand the information that's in textual data, like social media or clinical notes.
That's awesome. Thank you very much. Wendy, as you can see, many people are tuning in from different parts of the world, from Israel, India, and we have people from Germany. That's awesome. We're going to announce the second panelist, Professor Enrico Carrera, Professor of Medical Informatics and Director, Center for Health Informatics at Macquarie University.
Hi, Steve, and thanks very much for having me on the show. And I want to echo your comments to all our colleagues in India. We really are thinking of you, and you are in our hearts at this very difficult time. Like Wendy, I also am running a research group, and our focus has been in digital health. Really, we've been at it for about 20 years now, and we've seen the world change dramatically around us. And a big focus for our group has been AI applied in healthcare. But not just machine learning and data, we're also very interested in what are the use cases for the technology, where is the technology safe to apply, where is it not safe to apply. So it's actually a broad blend of research, from very human-oriented, human factors work through to hard-edge machine learning. And we'll talk, I'm sure, during this session about the different areas we work in, but we've been looking at applying, say, deep learning for diagnosis of COVID, looking at the explosion of evidence around what works and doesn't work in terms of AI and the problems there. We've studied actually the way people have been self-caring at home pre and post-COVID, and that's been very interesting. And I hope we get a chance to talk about some work we do in serious games and on how that seems to help people deal with mental health challenges in COVID times, Steve.
That's awesome. Thank you very much, Enrico. And our next awesome panelist, Professor Souza, who is right now in the train going home. Thank you very much for tuning in. Russell, I know that this is a little bit going to be challenging, but we all would love to hear from you about your experience and what you're doing right now related to this particular topic.
Oh, a very good evening to all of you. I'm Professor Russell Souza. I listened to both our distinguished panelists. I'm a professor of organizational psychological medicine. I used to be the director of the psychiatry research at Melbourne University, but I'm now the dean of the International Institute of Organizational Psychological Medicine, based in Melbourne, Florida, and Melbourne, Australia, and Doncaster in UK. I'm also the Asia Pacific head of the UNESCO chair in bioethics, and cover much of the area of Asia Pacific region, which includes Australia and New Zealand. Much of my work, from my perspective, I think I was going to talk a little bit about some of the issues with the workforce and the in terms of psychological health, but more importantly, the current situation where we do have um, um, problems with technology, which has taken over much of our work in terms of the working from home and the impact of that we are seeing on boundaries and where psychological health is. I am a clinician and a researcher, but so I will come back with some of those information. I want to apologize to all of you. I was to be in a little earlier, but unfortunately, due to I was actually I joined in because all the others were able to only fit today in. But I'm traveling and should be back a little bit delayed, so I'm in the process of travel. So my apologies for the if there's any break there, but I'm there with you. So look forward
No worries.
to today's World Innovation Day, and certainly technology, psychological health, and so forth will be what I'll be talking. Particularly, there's an interest. I'm going to be trying to bring it home the importance of presenteeism, the current situation with where all of you have heard of absenteeism, but in the last 10 years, a lot of research, 10 to 15 years, is looking at presenteeism, where people are present but are unable to um, do their optimum, not because they don't want to, but because of subsyndromal issues with both psychological and physical. And this is particularly to the workforce. The current estimates is that Australia is probably losing something like 68 billion on presenteeism, that is someone at work but unable to perform their optimum. And it's interesting because today's research, presenteeism has now become 4 times more costly than absenteeism for the workforce. And of course, organizational psychological medicine is about the psychological issues on the workforce. And nowhere, no time has it been more relevant as in the COVID times. So happy to join all of you, and delighted to be here. Thank you very much.
Thank you very much. So I'll go back to you, Wendy. That's it seems that you are involved with some interesting projects. Especially, I would like to dive deeper into your observations around the challenges that we are facing, and in terms of, like, we all hear about the normal challenges like depression and anxiety, but what are your observations through the projects that you are doing, and is there any specific data that we gathered through this pandemic that would help us to navigate through and become more resilient in future?
Yeah, thanks. I think that all of us have realized that the social network around us is really important to our mental health, and that COVID has disrupted that for us. And I think there's a new report here in Australia that recommends that the idea of social prescribing, and that be incorporated into routine healthcare. And that is, prescribing not medications, but things like you should do meditation or you should go to a gym. So things that are outside of medicine. And those of us who aren't physicians have known this for a long time, that it's not only about what physicians give us that contributes to our health. But they're saying that we need to do this social prescribing, that GPs should be doing this. But there really isn't good infrastructure to support GPs in doing this. There's not a lot of evidence about how to do it. There aren't evidence-based ways to build partnerships between patients and GPs and really get information from the patients that help drive the types of social prescribing. What are the areas that are most causing harm to the patient in their lives, or most missing to the patients? There aren't methods for measuring if they work. And so I think, the need for tools and frameworks to support and do research and drive evidence about best processes for social prescribing is one of the big needs that isn't talked about a lot. And Lynette Joubert who's at the University of Melbourne. She's working in this space and has really brought that to our center as something that she has some evidence for in decreasing need for the suicide rates, and trying to figure out how do you implement that into the healthcare system.
Awesome, that's great. We'll get back to that a little bit later. So, Enrico, I would like to hear a little bit about your project and research that you're doing, and if you have also any comments about other panelist discussions.
Sure. I think one of the things all of us are participants in the pandemic. We're not just researchers watching it. And as Wendy was speaking, I was reflecting on my own experience trying to navigate a group of about 35 researchers from the early outbreak and the anxieties that developed there, to shifting to working at home and prolonged lockdowns, not as long as, say, Melbourne had with Wendy. That would have been exhausting. But just realizing that simple things like social connection through Zoom were critical to people staying focused. We did very trivial things like every day at 10 o'clock on Zoom, we just called it coffee time. Nobody was required to come and have a cup of coffee on Zoom, but it was a way of recreating those meetings you would have accidentally in the physical space. So although nobody likes Zoom or online compared to real life, we were able to engineer enough that people felt connected with each other still in a random way, as well as talking to their friends, and for everybody to have a sense of purpose and have work that could still continue. So those are just my own personal reflections on what we went through in that readjustment. And my own view is that we did much better than I thought we would do. I've got to say, had you described the world of Zoom to me 2 years ago, I would have said it would have been just unacceptable. And now we know there are a lot of pluses and a lot of minuses. I have to say we are lucky enough now to be back on campus, and so real life is still better, I have to say. In terms of research, there are just a couple of things I would like to pick out. One is a program on what we call patient work, where we are very interested in not what are the tasks of the doctor or the nurse that they're supporting, but what are the tasks that a consumer or a patient have to do every day to manage their condition. And we were focusing on chronically ill patients, and we're going home, observing them. They wore little body cameras so we could take pictures of what they were doing. And it just so happened that happened in the year before COVID, and we've been following them up post-COVID. I think from the perspective of this discussion, the thing I'd like to share is that because of the rapid move to telecare, a lot of patients remained even more engaged than before with their chronic care. So maybe in the past they would have visited physically infrequently. Now they were getting light touch, more frequent online interactions. And so that actually was beneficial. The other one I'd like to mention, because it's intriguing to me, is some work one of my teams has done on serious games. And in this case, the not so serious games, they surveyed 2,000 players of Pokemon Go and Harry Potter Wizards Unite, which, as some of you know, probably are these massive global online games that require you to walk into the world and to physically interact with the real world to get your points or whatever. And so we surveyed them for mental health. And I think what was interesting was that more than half of them reported low quality scores for mental health. But there were two big consequences of staying engaged with these online games. The first is that although their exercise rates dropped, and we know exercise is important for mental health, participating in the game got them out of the house and still got them walking and staying engaged. And they all reported mental health benefits, whether it was distraction from stress. For those who maybe didn't have work they could do at home, it was purposive work they could do. So it's interesting to us that there are ways of engaging socially. Wendy, you mentioned social networks. So this is a different kind of social network with a different class of engagement, but it seems to have mental health protective benefits. And as a parent, I always worry that playing games reduces exercise, but at least for this class of games, it seems to have maintained exercise rates, or at least avoided massive drops. So two very interesting studies.
Yeah, no, that's awesome. I totally agree. Some of the new games, especially augmented reality and new games that um, we're saying that needs more engagement from the players, or kind of replacing the old games where you just need to look at your monitor for a couple of hours, and it would definitely not be helpful. So the good news is our other panelist, Scott Newman, just joined us. Thank you very much for joining, Scott. So Scott is a senior director, cloud platforms and infrastructure solutions engineer at Oracle ANZ. It's good to have also someone from industry joining our awesome panelists, and bringing some of your experience and what you're seeing in from the industry perspective happening, and if there is any specific projects that maybe you can talk about that you've been involved with. We would like you to share your perspectives as well. Scott, you are mute.
Right. And I'm the technology person too, right? So apologies all for the late joining, and I really need to do something about my title. It's a bit of a mouthful. Let's just say that I work with data and technology in line with Oracle's mission, which is to help people to see data in new ways, discover insights, and unlock endless possibilities, which I think is very much in line with the topic that we're talking about today. I've been working with technology for more decades than I care to count, and quite lately, with the increasing pervasiveness of technology and the fact that more people globally are so digitally connected, there is just so many more possibilities that it's so much more possible to drive data-driven outcomes, to use data and artificial intelligence and other technologies to drive fantastic outcomes. Oracle is, and personally, I've seen the interruptions that have occurred in health globally around immunizations, healthcare, education, etc. And it's been tragic to watch occur. And I think that technology as an accelerator has a real role to play here in helping us to get back on track globally. One of the things that we're doing in Oracle to that end is offering free vaccine management rollout. We're working with the Tony Blair Institute to roll out yellow fever vaccines, HPV, polio, etc. And when COVID becomes available in that part of the world, it'll be used to roll that out here. There's a lot of interest in Asia Pacific around that, and of course, it's getting traction in America. There's a lot of projects that we could talk about with respect to how we're trying to use technology to help with mental health. But I think the one that most comes to mind is there's a piece of technology called Yokeru. It was spawned from the idea that something could happen for someone who's at home and isolated, either because they're from an older generation or just because they're isolated due to the pandemic. And if something happens to them, it would be difficult to know, to be aware that event had occurred. So the Yokeru technology initially was born based, again, using artificial intelligence to look at electricity usage patterns. And a variation in that pattern may have triggered a change in behavior or a change in event, like, for example, someone fell down. However, AI can go, as we all know, can go much, much further than that. And it was in the UK, it was linked into a government rollout campaign to just monitor the needs, the healthcare needs and the medical needs and the basic primary needs of individuals who were in what they were calling shielded, or as we would say in Australia, in lockdown. By using an AI-driven telephone system to call people, they were able to quickly assess where the needs were the greatest. And when you had limited healthcare workers to get out and get to those houses, the findings of the phone calls, which were AI driven, appeared on a dashboard, and the healthcare workers were able to use that and meet the needs, be they mental health, medical, or whatever, more efficiently. Using this process, they covered about 9,000 calls a day. So it's a really cool story around how technology, data, and AI, etc., is really doing its bit to get out there and meet some mental health needs.
Awesome. Thank you very much, Scott. So we have lost Dr. Souza, I guess. Yep, no, he joined us again. That's great. All right, great. We do have Professor Souza again. Hi, Russell. Can you hear me? Hi, Russell.
Yeah, I'm sorry.
All right, no,
As I
that's great.
apologize, I'm having this problem. But yeah, can you hear me?
Yes, no, awesome.
Good.
That's great. So first of all, let me ask our awesome viewers to send us questions. If you have any questions you would like me to ask from this panel of audience, please, the panelists, please send me through. We have around 180 viewers online, which is great. So please join us and help us to answer any of your questions. And back to you, Russell. So I know that you're doing amazing work and research about mental health and specifically, and I think we lost him, so we would go back to him later. All right. That's fine. That's the some of the problems that you will see when you're live. So it's totally fine, and we will go through by talking about a little bit about Australia, about bushfires and the flood that we have probably all experienced in last 2 years, and it affected all of us directly and indirectly, which I guess it is something that we would like to talk a little bit about it and see if you have any experience or any research has been done through these years that can give us a bit of more overview of how it has impacted Australians and if it is any different from the pandemic, and any of your perspective. I'm happy any of you, if you have any.
I can have a shot, I guess. So for those of you who are listening who are not in Australia, we had probably a 3 or 4 month rolling national emergency with bushfires about 12 to 18 months ago, and they really overwhelmed our resources and people revolving strategies for dealing with these fires as we went. From a health perspective, what I thought was really important was that the governance of our country is we have a federal government and we have state governments, and the state governments essentially have the job of providing services like fire services or health services, whereas the federal government essentially has the large purse strings. And we could probably say, Wendy, truthfully, that the first few months of that relationship between federal and state governments was dysfunctional in the fire. But towards the end of that, they really had got their act together, and there was a war cabinet, and they managed day by day to deal with that. And just as the fires finished, COVID came. And so I think we had ironed out a lot of the dysfunctions in the way we would manage a large strategy through fire. So one of the reasons I think Australia now is in a relatively good position in terms of community transmission is that we got that governance right. The other thing I think that we did have from a health perspective is we have a 2/3 public, 1/3 private health system, and we have heavily invested in population and public health services, which are publicly funded. So we had people trained in contact tracing. We had infectious disease control teams already in place. So we were able to scale very quickly. So my perspective is those were two meta issues which have resulted in us, just by luck, doing perhaps better than we would have done compared to similar nations like Canada, for example. I don't know, Wendy, if you agree or disagree, or Scott.
Yeah, I would agree on the high level. I would say that the way that the different states have handled contact tracing has been different. And it's my understanding that in Victoria, it was a very antiquated system with faxes and PDFs, and that caused a lot of slowdown. And we weren't able to scale it as well as New South Wales, in theory. I would say that there's a similar, something that they all have in common is this need to collect and share data from a variety of sources. And we don't have the infrastructure for doing a good job of that.
Yep. No, that's an interesting observation. Scott, do you have anything to add, or you're still on mute? Yeah.
Yeah, that's right. There's a lag when I hit it. I tend to agree with Enrico that the lessons of the bushfires, whilst from a mental health point of view, were not ideal because we went from one crisis to the next. They did set us up to be in a responsive mode. As someone who travels around a lot in my job, the differences in the way that we do tracing, I think, was an opportunity missed for us to be able to share and learn. My concern, I think we've got it under control, though. We've certainly got it under control now, and the data and the cases support that. My concern is for when we come out the other end, we've all been vaccinated, but the virus is still around. I'm a little bit concerned about the social behavior that will occur as we start to take our health for granted, because the data will start to fall away. We won't be able to track and trace as much, and yet there will still be a need for insights and learning. We'll want to learn about how the vaccine's taking effect. We'll want to learn that we're still a part of a global community. So it'll be interesting to see how we handle the post-COVID world where there is still a need for data and insight.
Yep. Yeah, thanks, Scott. We do have Russell with us. I want to see if we can have his insights as well. Hi, Russell. Can you hear me? I think he's probably having issues connecting, which is fine. All right. So I would like to talk a little bit more about the technology part of it, because most of our audience right now are super excited about the AI and data science and machine learning and all those stuff that we are hearing, the buzzwords. And actually, they're very interesting topics apart from being buzzwords these days. So maybe we can talk about the applications and what technologies that we are seeing that are affecting and helping us to, navigate through these crises. And is there any specific use case or application that you're excited about? Maybe starting from Wendy.
Okay, I thought Enrico would start because he's the king of AI.
You will go to the king afterward.
So you're asking about AI use cases for COVID?
Yes, especially healthcare. And if there is any specific projects or maybe ideas, startups, or anything that makes you excited about, and yeah, that might be inspiration for others that are listening. It's to search about it and dig deeper, and get more insights. Because for example, I can hear a lot about the chatbots and the conversational AI that are helping people navigate through this crisis. And a lot of people are actually starting to more and more trust AI to have a dialogue, and that's a very interesting topic to think about. There used to be conversation. I was part of a lot of panels before about AI and conversational AI, and people were like, we are not trusting AI to get some very specific sensitive information and rely on chatbots for that. But we have seen from the statistics that it seems that people are changing their mindset, and they're having this kind of closer relations with chatbots to get actual psychological help, and that's interesting for me. And I would like to see if there's any of these use cases that you have observed in the last couple of months.
Yeah, I am going to turn it to Enrico, because what I have is like some challenges, and I'd like to hear Enrico's ideas of exciting things. It looks like maybe Scott can mute.
Yeah, Scott. Yeah,
sorry.
So I'm not sure I would call myself a king or even a prince. I think I'm just an activist is what I am. So look, I think the whole story of AI in the pandemic has been a really interesting one. AI has been tried across the board for all sorts of tasks, but if you look at the geological history of the pandemic, probably the first year, machine learning didn't rate because there was just no data. We just did not have the data sets to do deep learning, etc. And when data sets did come in, they would often come from just one group and wouldn't necessarily translate elsewhere. So the next big phase was people would get their hands on usually small data sets and produce apparently very promising results. And in fact, there are literally thousands of papers published in arXiv and bioRxiv, which were not peer reviewed, which really didn't stand scrutiny when you look at the larger data sets. And there's a fantastic review that's ongoing in the BMJ on COVID predictive algorithms. It's a sort of a living systematic review. And it really points to the challenges with when you don't have good data and good comparisons, that a lot of the algorithms might appear to be doing well, but they don't. So I think that was very important. And people often say, where is AI? And the answer was, well, we don't have the data, so we can't help you right now. Now that's changing. But say for a country like Australia, where we've had very few COVID cases and very few deaths, an extremely lucky country, we can't play in that game because we don't have the data. So where did it work well? So NLP, Wendy, actually is one of the tools that worked really well. So Boston Children's Hospital has a technology that looks at social media streams, news reports. It's called Health Map, and they detected the Chinese outbreak early in December in terms of their algorithms and saying there's something going on here. So certainly from that perspective, AI played a role. We're seeing AI play a role in vaccine design, both in terms of identifying targets for vaccines as well as molecules. There's also, I think, real opportunity for AI in repurposing existing drugs to treat COVID. So being able to look at large data sets of patients who are being incidentally treated with other drugs for their diseases, and some seem to just by chance to be doing better than expected. It might turn out that your diabetes drug or your blood pressure drug is causing that. And so what that does is generate candidates for scientists to then go and do formal trials on. I think it's a real story of what I would call the classic digital health problem, which is that we often start with the technology and we don't start with the problem we're trying to solve. We often talk about healthcare needing to become digital first, but I really think it can't be health second. So we have to start with the compelling problems. And I'll finish with a good example, which is out of the mental health story, but there are very many papers on diagnosing COVID from chest x-rays because there are a lot of chest x-ray data sets out there. Turns out we can do it very well, but it's actually clinically useless, because what we really want to do is to mass screen asymptomatic people very quickly and cheaply, and that's where PCR tests are so important. Trying to use AI to diagnose you on chest X-ray means you present at a hospital, you've already got serious disease. It's just the wrong part of the workflow. It's a great machine learning task. So I always implore my computer science colleagues to make sure when you embark on any of these projects, to make sure you have strong clinical partners, to make sure you're actually solving a problem that would be worthwhile solving. I don't know, Wendy or Scott, if you have reflections on that.
Yeah, I think that's a really excellent point, and I'll add about you need to have the data to be able to do this, and you need to be able to integrate data across different places. And the raw data often isn't enough. A lot of data is contained in text, and so you need to process it. But the way that data are represented are really important in being able to learn from them. So one example is a bunch of different hospitals in the U.S. all mapped their COVID patient data to the same data model, and now they were able to integrate data from many different institutions and do some learning about symptoms of COVID, treatments that were most effective, the outcomes on a scale that no one could do in their own individual hospital that had much smaller numbers. And so being able to represent the data in a way that can be merged and shared is really, and a way that can be processed is a really important part that is often ignored.
Yeah, that's a great point, Wendy. I totally agree, because in order for AI to learn, you need a lot of data available, especially for complex problems like identifying what processes or medicines are working better. And because of the complexity of the problem, I guess this should be a worldwide initiative rather than a national project. But of course, there are some ethical challenges and other data sovereignty challenges that we all know that may need some help from United Nations or other, I guess, broader initiatives and organizations. Scott, do you have any observations specifically about the usage of data and AI that you're seeing across maybe the tech or industry in particular?
Yeah. Hi, Steve. Yeah, thank you. Yeah, we do. It's interesting. There is a lot of concern and some confusion around using data for the purpose with which it was collected in order to comply with regulations, be they domestic or international. And that is causing some confusion. We speak of the concept of data liquidity, or the ability to use data in a different form for which you, with some agility, have the agility to use it in a different way to which you originally collected it. But you do then find yourself having to comply with certain regulations when you're doing that. It is getting better understood, and the demand and the opportunity, be that in health or elsewhere, is driving a rapid clarity in this space. There is a lot of desensitized data. There's a lot of ways that you can use that data and still comply. So there's still a lot of possibility. But I think the biggest challenge that is being faced as people explore this is that they don't quite understand what they can and they cannot do. And so there's paranoia about going too far. There is also still emerging capabilities in a lot of spaces where people are learning to store and combine data. And whilst I agree with my colleagues here that you can never have enough, that the more that you have, the smarter your models are, there is now also emerging the idea that maybe there is too much data, that it's actually muddying the waters. It's actually creating a distraction. It's noise. Now, that said, I would agree with both you, Steve, and also Wendy and Enrico. We are seeing that there is a bigger appetite for people to speak to bots, for people to interact with AI, and share insights. People are quite comfortable doing that in studies that we're seeing. Even for mental health, they're quite comfortable talking to robots. They feel it's going to be a more objective and swift response. With respect to combining data, we're working with companies that are doing genomic-based cancer research. And of course, the genome, there's a lot of data associated there, and being able to use models that they're exploring, so applied precision medicine, for example, models that they're exploring there around certain treatments with increased efficacy, they're able to compare data sets and models from different researchers to get an even more accurate view. And it's, again, it's just something that's possible. It's not so much AI, but it's possible now due to the massive amounts of data and the machine learning models that we have at our disposal.
Totally agree, Scott. Thank you very much. So I will, if you have any anything to add, otherwise I will go back to our audience for a couple of questions. We also have Russell. Can you hear us, Russell?
Yeah, my apologies again. I'm in and out, but in the next few minutes, I should be more. Everything should be back. Should be good. Yes, I can hear you.
Awesome.
I sort of listened to Wendy and her thoughts about mindfulness and all this. We've been using Wendy. We developed the spiritually augmented cognitive behavior therapy using the technology to reach out. Of course, this is not necessary only for COVID, but beyond and before that, for indigenous people in Broken Hill. When we were there, we were using technology to give them access to some of the, as you said, using many of the cognitive behavioral techniques and so forth, not only for depression, but indeed for demoralization and so forth. So, and right now, while Australia, as Scott and others have noted, we in Australia are very lucky. But I cover the Asia Pacific region where things are not as, in fact, we are dealing with many other countries that are indeed having major problems at the moment, and in fact for the last little while. And some of the things we've been using, particularly, of course, now everything has come to virtually a standstill from the
Unfortunately, we lost Russell. That's all right. We will continue with with a question from our audience. So, what would be the future? Let's go a little bit in the prediction mode about the future, and see if we have Russell back.
I'm really sorry that I am in this situation. But look, yes, we've been using from the organizational psychological medicine. We've been using some programs now virtually on what we call valuing the human capital, looking at some of the areas that modules where we are trying to get using virtually. In fact, we've used this program on experiential learning within the senior executives and workforce of many of the some of the hospital executive from many of the other dealing particularly also with the workforce, the healthcare workforce, which is we are talking of a significant impact of this pandemic on the workforce. Such areas we've seen for the first time moral injury, moral distress, and the impacts of that, which go on to toxic stress and so forth. But we're trying to use. We've been using now these virtual technology to try and bring these people and try to use some of the modules we've developed in trying to bring resilience in particularly. We are using it also for the executive, the corporate areas, but particularly we have been using this with the workforce, the healthcare workforce, and so forth, trying to cope with this the current situation that we have. So I see we see technology as an important part of giving access, particularly when access has become.
Okay, sorry everyone. That's just the problems that might occur when you're going live and the technology is not always helpful. These are totally, I guess, normal um, when it's a live event. So I'm going to get one question from the audience, and then we can go back and check in with Russell again. So what would be the so this is from Conrad. What is the most important I guess use case that needs to be solved? And that's very, very broad. I would say I would go back to our I guess topic, and will be in healthcare. So um, anyone wants to contribute an answer to this question?
Well, I'll give my biased answer of that language. Understanding language is the frontier that hasn't been cracked yet. And for us to really interact better with computers and mobile devices, we need to crack that.
Awesome. Yeah, that's. I guess I've actually seen an HBR article from one of my colleagues that he was talking about the next important, I guess, project that we will see to be rolled out will be about NLP and cracking the language. So looking forward to that. Enrico.
Yeah, I can see that it's a cheeky question, because if I tell you the best AI healthcare use case, you'll create a startup company and get very rich, and I won't. So my cheeky response is that there is no such thing, but where you can demonstrate a critical problem and a genuine economic and clinical outcome, you're on the right territory. If you're excited by the AUC, area under the curve, of your machine learning algorithm and how precise it is, you will never make a dollar, because we don't really care about what's in the box. When it comes to digital health, what's critical is, where does it fit in the workflow? How does it help the job we're doing? Is it cheaper and more effective than what we're currently doing? And most importantly, will patients be better because of it? And that's not an easy needle to thread. I've seen many major companies over the last 20 years, giants of health, of IT, just stumble in healthcare because it's such a complex domain. There is no simple answer. There is no magic bullet, and every step is like trench warfare, I think. Occasionally there are massive innovations, but I do think it's tough. The last thing I will say is that healthcare is local. So the idea that you've got a single use case that works everywhere just doesn't fit the reality. A hospital, even two hospitals in the same state in one country, will see different patients and do things differently, let alone, two hospitals in different nations. So I'm not sure there is an Uber in healthcare. If there is, please let me know, and I'll provide startup funding for you. Thank you.
Awesome. Scott?
I would probably just say, related to Wendy's comment, I think that education will go a long way to people having a healthier lifestyle just through a greater awareness. So if we can use AI to translate and make available through connected devices or whatever, greater access to information, I think there's a lot of improvements in healthcare that can be achieved just through the dynamic provisioning of multilingual information as and when needed for people.
Thank you very much, Scott. I guess we're kind of getting close to the end of this panel. I would like to thank all of the panelists and you, amazing audience, for the participations. You shared a lot of interesting questions that we haven't got through. Some of them we tried to answer through the discussions, but I urge all the panelists to tune in later and maybe engage and answer some of the questions that has been shared. And looking forward to seeing everyone for the next event. We are going to talk about education. There's going to be another panel pretty much the same time tomorrow, and it is going to be an interesting one. So thank you very much, and hopefully talk to you later.
Thanks, everybody.